Welcome everyone to the Unboxing Careers Podcast. I'm your host, Greg Zackwitz. On today's episode, we explore a career in hematology and oncology with Dr. ADEEL Khan. So ADEEL, welcome to the show. Thanks for being here.
Thanks so much for having me. Pleasure to be here.
This is, I'm in the medical niche right now recording, and I'm getting all these professions that I know very little about. So I kind of have a high level about what you do. And that's about where it stops here. So this is going to be learning for me as well as the audience who's listening today as well. So I'm excited. ADEEL, let's start with this. Let's do some level setting. Quickly tell us about your current role and then how long you've been in the industry for.
Yeah. So I've been a hematologist-oncologist for a little bit over 4 years now. I started here at the University of Texas Southwestern Medical Center in 2022. And I focus on blood cancers, and particularly one specific type of blood cancer is my baby. That's called multiple myeloma. But I focus on a lot of oncology, a lot of cancer care in general with some of my research. But my clinical focus is the blood cancers.
Okay. And when did you know you wanted to go into the medical field as a career?
Yeah, I was influenced very early on by my parents. So they're both doctors. My father is a pulmonologist and critical care specialist. My mother is an obstetrician gynecologist, and it was in some ways an assumption that I would pursue medicine or at least think about it. And so I think I was genetically disadvantaged to that, but I very much loved it, and I think in part it's because of the way they spoke of it. The science of it was fascinating. And there's so much potency in just the fact that these are such meaningful conversations that we have with people in a sensitive time of their lives. And so early on, I thought about medicine. And I think when I eventually then got towards college and then towards certainly medical school itself, you have to pick what you want to do. And amongst other things, one thing that was just so fascinating to me was cancer. I think culturally it's so much potency there. Everyone's lives is touched by cancer in some ways. The research is so fast moving, and it's really something that allows you to have a lot of impact in someone's life. And so I knew kind of early on that I wanted to do hematology-oncology. I knew pretty much from my second year of medical school that that's what I wanted to do, and I did not change. I wanted to do blood cancers from that point, and I pursued it to every single day thereafter to voila, here I am now.
So a lot of people will talk about kind of going through medical school and kind of having their hands in a couple things. That's generally where they feel they either find things they really are drawn to or find things they know they do not want to do. And I think both things are great to do. Always good to know what you don't want to do. Was there something, you said you've always been drawn to it, but was there something when you were going through medical school where you're like, hey, I think I want to do this, and then you got exposure to it and it confirmed that yes, I did want to do it? Or were you just laser focused on doing this and you went with it?
I'd love to say that it was a calling that always brought me in, but I think the reality is that for one, I definitely knew things that I did not want to do. I realized I didn't really want to be a surgeon. I didn't want to do, there are certain areas of biology that didn't particularly pique my interest. And so, medicine, while we're focused on that, just didn't make sense to me. But I think when I was in my second year of medical school, you go through a lot of topics, really top to bottom. You go through all the body systems. And I just had a very interesting hematology-oncology section. I had some great lectures on leukemia, on lymphoma, on multiple myeloma, on just the way that the body makes blood, hematopoiesis. And I just found it click. And so I said, yeah, I think I can do this. And then I just didn't change thereafter. And I've really enjoyed it from that point forward.
Very good. And if you could kind of walk us through, you go through med school, you go through your residency, we get out of everything and we get into the real world job. So like most things in the medical profession, there's a couple of avenues you can go, right? A lot of times you can
100%.
go into patient clinic, you can go into the research side of things. Walk us through kind of maybe what you did when you were starting out, and then whatever maybe is on the side of the table that you did not do.
Yeah.
Talk about, if you can, some of those other paths
sure.
that someone could choose if they go into this.
Yeah. So, when we think about a doctor, a physician, we think of the patient care, and that really is vital. That's really kind of our central focus. But there's so many other things that go into that, from the research side, the teaching. There's administrative work, which is not necessarily the most luxurious. But all of that is vital to delivering the best care to a patient. And the path for medicine is known to be long, right? I think that's kind of famous.
Yeah.
For what I did specifically, 4 years of college. I did 4 years of medical school at the University of Michigan. I then did a residency in internal medicine, which is very broad, everything from cardiology, endocrinology, etc. And then a fellowship in hematology-oncology, focusing on cancer and study of the blood. And then that's what makes me the hematologist-oncologist that I am. And along the way, auxiliary interest that I had developed was a very serious one in public health. I really found epidemiology and the research tied to it fascinating. And so a lot of the work that I do is, in fact, cancer epidemiology. So a different hat that I had put on, actually, really around the same time, was public health school. And I did 4 years of public health training in the midst of this as well. And so merging all that together, I said that, being an academic hematologist-oncologist is really for me, focusing on cancer epidemiology is what I want to do. And being a professor then has been really what's allowed me to pursue all of those. So I get to do patient care, I get to do research, I get to do clinical trials, I get to teach, I get to do a little bit of the administrative work, and it all kind of melds together into this one job. Now, that being said, a lot of people can take a medical degree and do very different things. So you could be in clinic day in, day out, if that's what you want to do. You could do even all your clinical care in purely a hospital if that's also something that you want to do. Those are all bona fide options, and a lot of people who go through med school will, in fact, do that. And then there are people who pursue 100% research careers, and that could be actually at an academic university setting. It could also be in industry. You could work for one of the big pharma companies and pursue, a study of enzymes in a lab somewhere. And then you can do clinical trials and clinical trial management. You can do administrative work and making sure that people get the optimal care. Managed care insurance companies also use doctors to make sure that the care that they are allowing and putting forth is, in fact, let's say, as optimized, quote unquote. And so there's a real diversity in what you can do with the degree.
And you mentioned that you're doing a lot, right? You have your hands in a few different things. When you're starting out, is that generally what you do? You have, say, research days or in-office days, you have clinic days, things like that, and then you navigate to, as you advance or become more senior, you navigate to kind of the setup you want, or can you choose that right out of the gate in some cases?
Yeah, I think to some degree you kind of take what's given to you at the beginning, and then as you become more senior, you can sort of make your own blend. In my own case, the way I kind of like to put it is, if you contrast me to someone, let's say another hematologist-oncologist who's in clinic day in, day out, in a way, their diversity of activity is the fact that they are probably seeing all sorts of cancers. They're seeing breast cancer, lung cancer. They might see people with anemia. They'll see people with multiple myeloma, but they're just doing clinic. And I quote in quotations, it's very worthwhile work, but they're focusing on clinic.
Okay.
In a way, my diversity then is very focused material, but a lot more diversity in activity. So I focus, again, mainly on the blood cancers. And even then, more specifically, a specific one called multiple myeloma, cancer of the plasma cell, type of white blood cell in all of us. And that's my main focus. And then my diversity of activity really is the fact that I do retrospective epidemiologic work in that realm. I do clinical trials in that realm. That's what I teach. That's the administrative work that I do. And that's the clinical care that I do. So it's kind of how you want to slice it. So in pursuing that, I've taken, really all the opportunities that are granted to me, and you fight for them as well, to then have all those things on my menu, if you will.
Did you decide to do that because you wanted to? I don't know how to say this, but like you don't go through the motions every day, right? It's not, you get a little more variety and spice of life, if you will, right? Being able, but you also be able to tie things together. I can do research here and I see how it ties to someone inpatient here, things like that. Was there a strategic reason, or was it more just to keep things fresh so you don't get burnt out?
I think a little bit of both. I think one thing that I wanted to do to the best of my ability and to what a degree I have was I wanted to be what we call a content expert. I really wanted to know my field in and out. And so I've been very privileged in that vein to know multiple myeloma quite well, to do fortunately well appreciated work, to give talks nationally, even internationally. And so that was one thing. So in focusing on that, again, the diversity that you have to add to it is with the activities that you pursue within that domain, which ends up being all of those things that I mentioned, from teaching to research. And I actually have really liked that
Yeah.
because as I start to get burned or a little bit burnt out with one thing, you can kind of put your energy in something else. And then you can kind of move over to something else beyond that. And in kind of cycling, you get something a little bit more refreshing each time. And the fact that you're working with different crowds, different colleagues, different trainees, different students, different nurses and fellows, what have you, it adds a lot to what's on your plate in a good way. You know, you really get to see different aspects of the field. And again, it just keeps it fresh. It keeps it interesting. No 2 weeks are exactly the same. And, putting it all together, it makes for a for me, very satisfying career.
Very nice. You also mentioned because of the numerous things that you're involved in. Can you walk us through? And I know this will vary based on probably season and week and stuff, but what a typical week might look like
Hmm.
for you. How many days are you doing clinic work versus academia versus
Yeah.
research? Can you walk us through that a little bit?
Yeah. So I'm here based at UT Southwestern in Dallas, and um, our cancer center, our clinics, our hospital, our research labs, our offices are all really on the same campus here. And so for me, I come to campus, essentially every day. My Mondays and Thursdays are in clinic, day in at the beginning to day out at the end. I'm seeing patients in clinic come to me with blood cancers, mainly multiple myeloma and associated diseases. And then 1 week, roughly out of every six, sort of depends on the way the schedule is made, I'm in the hospital. And I'm at what is called a bone marrow transplant unit, where we're seeing patients with all different kinds of uh, blood cancers and doing that for the full 7 days. And I'm on call during the day as night as well for needs that arise. And I rotate that service with my colleagues. And those two things end up being my clinical care. Then the rest of the 3 days of a week when I'm not in clinic, those end up being my research and admin days, and administrative days. And so that's where a lot of the work that I do, it's large data sets, it's on a computer. And so a lot of it is facing, in fact, the computer. And then the administrative work is also, ends up being largely email, as I think most roles like that end up, a lot of Zoom calls, that sort of thing. And then I teach throughout the year. So when I'm on service, whether in the hospital or in clinic, I have either a clinical fellow with me, an internal medicine resident, or a medical student with me. And then I teach seminars here at our university. So I
Yep.
do one course, about to do a second one. And then some of my teaching is split across our medical school and our public health school, that being kind of the other half. So in one space, I kind of go to different spots depending upon what the specific schedule for that week is looking like.
Perfect. And do you mind if we dig into the clinic side just
Hmm.
for a minute? So you mentioned, I
Please.
knew very early on, I don't want to be a surgeon. Uh, can you walk us through a little bit about what exactly you do in clinic? So
Hmm.
you said you specialize in myeloma, which I believe, just in researching this, there is no cure for, but there are treatments available. So walk us through exactly what you do. Are you overseeing treatments? Are you
Hmm.
diagnosing? Are you doing something other than maybe we're not thinking of? Can you dig into the clinic side a little
Yeah.
bit?
Yeah. So I focus on multiple myeloma, which is a cancer of the plasma cell. Plasma cells are white blood cell types in all of us, and their main job is to make antibodies. So they're antibody heavy producers, and they largely live in our bone marrow. And when they become cancerous, that is the situation of multiple myeloma. Kind of a funny name, but you could rename it as plasma cell cancer. And so
Yep.
when I'm seeing patients in clinic, there's either concern for it, so I'm helping to diagnose it, or they already have it, and then I'm treating it with chemotherapies and immunotherapies. And so depending upon where a patient is in their journey, they're seeing me for one of those associated reasons. And there's similar diseases alongside that, like precursor states that I also treat and manage. But when a patient comes to me, there's some concern with a blood cancer, and so one, we're making sure that they're diagnosed if that's what they need. So we make sure they have imaging that they might require, whether it's a PET scan, MRI, what have you. that they have the lab work that's necessary, that they have bone marrow biopsies. That's like one of our main ways of diagnosing this. And then when we recommend treatment, it's conventionally chemotherapy, but also now immunotherapies and targeted therapies. And these are in some ways redundant terms, but they're all doing something different against the cancer. And so they have different mechanisms of action. And alongside that, I do clinical trials to then find more chemotherapies, more immunotherapies, more targeted therapies. And so when a patient comes to me, we could be anywhere from figuring out whether this is myeloma or something associated to this is a new diagnosis. I'm establishing a relationship, talking about treatment recommendations to someone who might have very relapsed refractory disease. We're making some sort of advanced stage decisions to at the very end where we have to talk about goals of care and maybe even hospice discussions. So it's a very full spectrum of activity that I see in clinic on any given day.
Thanks for the detail there. It sounds, I think you get this a lot in medical professions, also in, I guess it's still medical, but psychology is, it sounds like it could be a really heavy burden, a heavy mental load, because you're dealing with people at a very vulnerable and maybe some of the worst times in their lives. How have you found to be able to manage that mentally on those things? Because I've got to imagine,
Yeah.
like, you don't just clock out and go home, right? You're a human that cares about people, which is why you're in the profession.
Yeah, and sometimes the statement is that you take your patients home with you, and that's a very real thing. I think particularly in our field, you often bond with these patients for years, and when things don't go well, it affects you. And I'll say a couple things about that. One is that uh, I remember long ago one of my teachers said something along the lines of, uh, "You have to care enough that you don't ever lose your humanity, but you can't care so much that you lose your sanity." That there is a little bit of a balance there, knowing that you are doing everything that you can to support that patient, but that you're also recognizing that you're not in that exact seat and you can't be. It just doesn't end up being something that you can do going forward. And then the other side to it is what a different teacher taught me way back then in medical school, who said something along the lines of, and I'm definitely paraphrasing here, but the gist of it was that you can't do anything about the fact that people come to you with this disease, with this cancer, with this diagnosis. But if you care enough and if you're smart enough, you might be able to change what happens to them. And so in that way, I've actually found it very uplifting. And so, in talking about the issues of myeloma, so yes, but largely it's incurable, but the treatment advances have over tripled the survival in disease. It's really one of the success stories in oncology. In that way, I actually find it very uplifting. I think it's very hopeful that we can give people a lot of meaningful time, which means that they have that many more birthdays, they have that many more anniversaries, they can enjoy quality moments while feeling well. And so in that way, I fully acknowledge the downside and kind of the vagaries and the sad side of our field, but I don't let it outweigh the fact that we're giving them a lot of good moments. And which one do you want to emphasize? I choose to emphasize the positive.
Yeah, that's really well said. I like the lessons there from the previous professors as well. So thanks for sharing that. You mentioned kind of going into oncology and kind of some of these advances here. I've got to believe as that's, I don't know how to frame this, but advances is kind of exciting in the medical field for people going in, right? They want to be on something more cutting edge than stagnant, right?
Mhm.
So is it making, because there are more dollars, more focus on treatments for diseases that maybe were neglected. I'm not saying this was neglected, but maybe neglected in the past because we didn't know what to do with it. Um, is that increasing the competition from the oncology side?
It's in general, I think cancer as a field has had a lot of money poured into it, a lot of attention poured into it. If you take like breast cancer and Breast Cancer Awareness Month, where you then see pink everywhere. I mean, I love it. That's great that there's so much focus on it, and then it reflects also the enthusiasm for research funding, and that funding ultimately, and the patient advocacy groups that help support it. That's what really moves the needle forward in patient care. And so what were once, frankly, death sentences in the distant past have become much more controllable diseases. But that's still to acknowledge there's still a lot of work to do that we can do. As we learn more, we see that we find pathways that are quote unquote druggable, right? You can inhibit this, and you can then stop the cancer from progressing in this way, and that ends up offering something meaningful to the patient. So it's there's a lot of focus on all different areas of oncology, and in general, it doesn't always match what the prevalence or the incidence is of the cancer. It sort of follows what in fact can be done. So there's definitely a lot of common diseases that we would love to see more attention on, but for whatever reason, the progress might be more stagnant because it just might be a hard field, something hard to really move forward. And then there's some actually kind of rare disorders where it just so happens that there's like one molecule, one pathway that if you kind of muck with a little bit, you can make real big differences in people's lives. An example of that is like chronic myeloid leukemia, where there's really one mutation that if you mess with it and you give a family of drugs called tyrosine kinase inhibitors, one of which is called imatinib, you help these people achieve almost normal survival times compared to people who don't have then the disease. So, and that's it's relatively uncommon, but it just so happened to have something that was exploitable. So this is just kind of one of the interesting things of research that as you pursue, you never know what you're going to find unless you don't know what you can take out of it. But it keeps it very fresh, keeps the whole field very fresh.
Not bad. We were talking offline before we started recording today about we were talking about kids and careers in the future, and AI came up. You're on the research side. Are you personally using AI as part of your research, or is that not fully integrated its way over to you yet?
Yeah, yes and no. I think so many of us use AI in kind of casual use during the day, like looking up something, sort of an advanced form of Googling, whether it's one LLM versus another. There's a whole lot of enthusiasm for AI all over medical research, from like receptor analysis to, network meta-analyses, all these kind of different things that we can possibly do with a lot of large amount of computing power. I would say it's still very much in its infancy, and it still really remains to be seen what we're going to come up with. There's always talk on the side from not just our field as hematologists-oncologists, but also radiologists reading MRIs, CT scans, pathologists reading biopsy slides that maybe AI will take away our jobs, do our jobs better than us. But I will say that's a threat to everyone. I think that's an across the board concern in different ways. And I'm joking, but also maybe not. I think there's a lot of room that AI can help enhance what we do. But one thing that I will say that I really appreciate about what specifically I can do as a cancer doctor is if we talk about artificial intelligence versus, let's say, artificial empathy, that relationship that a patient requires to help them through their journey with, let's say, multiple myeloma or something similar, that really ends up being therapeutic, AI can't do that. I think I'd be hard pressed for an AI bot of some sort to be able to do that anytime soon. Who's to say what the distant future might bring about? But anytime soon within my career and my children's careers, I don't see that happening. That empathetic, personal, human connection.
So I read an article today that Zuckerberg is creating a lifelike of himself to chat with workers at work to make the CEO employee relationship better and more, I guess closer, even though they'll be chatting to a AI agent. So it might be sooner than you think.
Yeah, we'll see if that ends up being more alienating than welcoming. Time will tell very soon. I can already imagine the memes. Yeah.
I don't need a bot telling me I need a knee replacement.
Exactly.
I need the person telling me that. I want to talk about salary just for a minute. I'm not going to ask you how much you make. I think most people have the assumption that doctors do fairly well with their careers. You can deny, rebut that if that is incorrect. But you mentioned, I want to talk specifically about someone like yourself who is doing multiple things. And it's not uncommon for doctors to do research on a couple of days and things like this. But if you're teaching at a college and you're seeing clinic, you're doing research, are you generally wrapped under one umbrella and getting paid from one organization, or are they kind of add-ons where like Duke, UNC, UT, whatever it might be, large organizations, hospitals, schools built in. But say you're in a smaller area, can you do, hey, work for this hospital organization, but I also teach at the local, I don't know, not community college. It could be community college, but I also teach at a non-affiliated institution. Is that an extra? Can you break this down a little bit for me?
Yeah, I think it's a great question, and it all kind of depends on what you sort of contract to. So in the most conventional sense, like in my own case, my official title is assistant professor of medicine. That's my primary title. My secondary title is assistant professor of public health, and everything that I'm doing is under those banners, right? Whether it's the teaching, the research, the clinical care, um, all of it is wrapped up in some way under those, and so I'm paid basically one salary at the end of the year, and there's some fluctuation to that based on certain metrics, but by and large, that's my salary. And for the academic side, there's other things that can come in with grant support, with the talks that we do, the honoraria, but by and large, our salary is our salary. And we sort of famously make less than people in private practice. I think sometimes there's this thought that we're making more. But it's very well, no, we're not, and I'm totally okay with that because another saying in medicine has been that fortunately it has been particularly in the U.S., but in really just about every country on earth, it's compensated well enough that the saying is you die with money in the bank. And so it said if that's going to be the case, do what you want to do what you love, make an impact, because again, you'll die with money in the bank. So that is, I think, a very favorable thing about the field. And in my own case, not being someone who is in a practice model where I have to chase down every revenue aspect, I really like that because I get to do just what's good for the patient, and what I'm getting paid is what I'm getting paid. So I'm always kind of just making the right decision for the person in front of me, and I don't have to mess with the extra beyond that. That's not to scoff at people who do it another way. They're in fact delivering most of the care in the U.S., and I actually have a lot of respect for it, but it's a different model. And
Yeah.
and so if you have a more revenue-based model, your compensation is then usually very much tied to that. And should you pursue then beyond that something like an adjunct professorship or teaching position or research position at another institution, you're getting paid for that depending upon the hours that you're putting in and the gravitas that you're then offering. So, kind of as we were saying earlier, there's a diversity of things that you can do. You can finagle your own balance in what you want. But what I also acknowledge is that there's only so many hours in a week, and so to some degree you have to focus because you can pursue breadth or you can pursue depth, and it's not easy to do both. So you kind of have to work with what the blend is that you want and chase that.
Is it pretty realistic to kind of choose that when you're not only when you're starting out, but as you advance in your career, to be able to choose? I always say work-life balance. It's the most common thing. Some people will push back on that terminology because it means that you have to choose one or the other. But can you balance your life fairly well? Do you have control over that?
I think doctors are not famous for work-life balance. I think we're more famous for work-life imbalance. And it is what it is. That's kind of the way that the medical profession has been for ages and ages and generations. And I remember when I was doing my hematology-oncology fellowship in Boston, one of my attending doctors, she had this great line that it's less about work-life balance in this field; it's more about work-life negotiation. That sometimes you have to focus more on work, but sometimes you can focus more on life and family. But that being said, you by and large, yes, can have the balance that you want, right? There's plenty of opportunities to chase, and so you'll over time, ideally, you figure out what it is that you want to do, what you don't want to do, what you can cut, and what you can pursue to kind of get that balance that it is that you hopefully desire, whatever that slice of negotiation is. And so sometimes I have very busy weeks, like when I'm in the hospital, that's just unavoidable. But then I try to make sure I spend time with my wife and kids before that and after that in a way that keeps us all fresh and keeps us all going in the way that we want. So, with a very complicated way, I'd say yes, with an asterisk.
I always tell people it's no matter what field you go into, you're going to have good days, you're going to have bad days, right? And sometimes those balances can
100%.
be thrown off. I
100%.
think,
Yeah.
yeah. What would you say, Adil, is the most challenging part of your career?
I think it's probably the aspect of when patients don't do well. I think when if someone has multiple myeloma, and if I've known them and treated them for years, and suddenly, and it's usually actually not sudden. Usually they start to slowly decline. That's hard to watch. These are people who you've bonded with in some way. You've had conversations where they've heard about your kids, you've heard about theirs, that kind of deal, and you've seen their family members at visits. And so when they start to not do well, there is a tax that is paid for that. But the other side of it is, it makes me feel and reminds me that I'm doing something that's worthwhile, that's meaningful. And so that is that's hard, but it's also why I do it.
Perfect. I think I know the answer to this one, but I'm going to flip the script on you. How about the most rewarding part of your career or your job?
I think exactly the other side. There's so many cases where someone comes to me and they have uncontrolled disease, uncontrolled myeloma. They might have renal failure, the terrible anemia. They've got high calcium in a way that they're just feeling very sick. And when you put them on the treatment regimen, when you start them on chemotherapy, while there are of course side effects that go with that, by and large they do better. So where they once felt very crummy and they just couldn't believe that life had turned around so fast, um, they start to then feel more like themselves, and then they, as they express that appreciation and as they regain themselves, that's really a fantastic feeling.
Very good. And how about some things people going into this career that either no one tells you or that you personally were surprised by when you got into it?
I think, and this might be true of a lot of medicine, I think no one tells you of how much administrative and insurance related, pharmacologic related red tape there is. And that, in some ways, I think is a commentary of our American healthcare system specifically. But I think it's worth bringing up because as you talk to people, of a different generation of medicine, so from people who have been practicing for decades, from people who then are entering the field fresh, it's something that's very real. We talk about administrative bloat. We talk about how challenging it can be to get things approved by payers, by insurance companies. And it's a point of frustration for patients, especially who are on the receiving end of all this, but also for us in trying to move the needle forward and trying to make sure that a patient gets the treatment that they need. Um, and while I think I knew that throughout my training, once I'm in practice and seeing it all the more, man, it's I would love to see favorable changes to the American healthcare system.
Does it? I wasn't going to ask this, but does that change? Not how you. Well, maybe it does. Does that change how you advise someone? Because I could imagine insurance companies, like the treatments are going through from you are probably very costly. Insurance companies are probably, by and large, trying to not pay that if they can. Have you, like, how often? Maybe this is a better question. How often do you get to a point where an insurance company declines whatever treatment you propose? They cannot pay out of pocket because it is insanely expensive, and they can't afford it. And you are then forced to do something like your plan B. Does that happen a lot, or is that more? Can you generally massage your way to getting to plan A?
Yeah, there's a lot more friction than I think it should be out there. And as someone who's doing clinical trials, we're always trying to practice on sort of the cusp of research, in a ways that guidelines and insurance companies are certainly not necessarily caught up. So there are mechanisms to fight. So for one, all of cancer care is really very expensive. This is not just true of my field, but really everything. Unfortunately, sort of is what it is, and that's a whole other podcast if we decide to get into
Sure.
it. But then accepting that reality, how do we get the drugs? How do we get the treatments to patients? There are mechanisms to fight, and that's actually what I have to do more often than I would care to. There are things called peer-to-peer calls, prior authorizations. There are appeals that we do to try to get this regimen to this person or this immunotherapy to this person. So we're usually successful, but it's not without some strife. And there are definitely cases where we just cannot get it through, and there are some administrative ways that we can try to handle that, and sometimes it's a matter of we're not the covered hematology-oncology practice for that patient. There's contracts that happen at levels far higher than me that,
Sure.
one company may pay for a set of practices and we might not be in it, or vice versa. So usually with all that finagling, something works out. It's to everyone's necessity, medical, legally, and otherwise, that it works out in some way. But the complexity of getting that point, I think, ends up being really tortuous and really convoluted in a way that I don't think is favorable for patients. And I do think that's where we do need systems change, and I would absolutely love to see that.
All right. So you are dealing with that probably, well, more than you like, but you are dealing with that. I don't want to say commonly, but it comes up.
More than I'd like to, absolutely. Yeah, unfortunately.
Very good. Thanks for sharing that, by the way. So
absolutely.
Don't want to get you in foul with any insurance companies or anything.
I'm speaking in vague terms for a reason, right?
Yeah, I appreciate that. Dr. Khan, anything I neglected? We got into a lot today. What did I neglect to ask you that would be important for someone going into this career now?
Well, one thing that I think is interesting, and this is true of not just medicine, but of so many fields. And this is advice a little bit from my father at one point, and my mother, and things that I had absorbed, that medicine has often been said to be a calling, but I think you could say that about a lot of fields. But more importantly than that, I think it's helpful to recognize that it's okay to not have a calling. And what I mean by that is when I made the decision to do what I wanted to do, which is specifically hematologic-oncology, focused on blood cancers, I can't say that it was truly lightning that struck. It was, again, something that I really liked, but I acknowledge that it wasn't necessarily a perfect field. There were flaws to it. There were aspects about it that I didn't like then. I still don't like about it now. But at some point, you kind of pick, and then you sort of learn to love it, acknowledging that there's never anything that's fully perfect out there. I think I often see, even people as far along in their careers, medical students or even residents, who are looking for this perfect one field with this one setup that's just going to fill every single criteria that they could have, check every single box. And I think the reality is, as we were saying earlier too, things are messier than that. So it's about more taking the reality that you have and making it work for you, and then finding a blend that you can stick with. And that's true of, I think, not just my field, but then every field. And so when I, in my own case, when I made that decision, I really didn't try to second guess myself. I really kind of dove into it and made it work in a way that I have really not thought twice about now ever since.
That's perfectly said. I think a really good way to end the conversation today. So thank you for your time. I really enjoyed this conversation. This was great. If someone wants to reach out, either ask you a question about the career, find out more about any organizations or universities, anything like that, feel free to throw out the best ways to contact you, check out websites, whatever you want to do here. Of course, we'll link it in the show notes in the website as well, but feel free to verbally give that out if you will.
Yeah, please. And for one, thank you so much for having me, Greg. It's been an absolute pleasure to talk about what I do and the passion that I have for it. For one, people can go to my website. It's khancology.com. So it's my last name, KHANCOLOGY.com. That is also my Twitter X handle. And then my email address we could also put in there. I love connecting with learners, people interested in the field. And so I'm very happy to connect with people and chat about what I do and about how I can bring them on if that's something that they're inclined to.
Perfect. So we'll link all that stuff in the show notes and the website. So Dr. ADEEL Khan, everyone, hope you enjoyed today's episode. If you want to explore other careers or share yours with us, just check out the website. Till next time, go Bills. And finally, go Sabres.